Hello, everybody. I'm Miguel Regueiro. On behalf of CME Outfitters, I'd like to welcome you and thank you for joining us for today's educational activity entitled Meeting the Needs of Underrepresented Patients with IBD, Screening and Immunizations. Today's program is supported by educational grants from AbbVie Incorporated, Janssen Biotech, Inc., administered by Janssen Scientific Affairs, LLC, and Takeda Pharmaceuticals USA, Inc. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. I'd also like to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. Again, that's at CME Outfitters. We'll be monitoring the Twitter feed and responding to your tweets as they come in. One last item that I want to note is that we'll be using an enhanced platform today that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. Please look at the tabs on the left-hand side of your screen and give us feedback on the program and on the platform as well. As I mentioned a minute ago, I'm Miguel Regueiro, Chair for Digestive Disease and Surgery Institute and Department Chair of Gastroenterology, Hepatology, and Nutrition at Cleveland Clinic in Cleveland, Ohio. So let's go to our all-star faculty, and I'm really happy to have these two joining me today. First of all, I want to welcome my colleague, Dr. Patricia Ajayi-Fox. She's an associate staff here with me in the Department of Gastroenterology, Hepatology and Nutrition at Cleveland Clinic in Cleveland, Ohio. Welcome, Patricia, and thanks for joining me today.
Thank you so much for having me today, Miguel.
And then also joining me is my colleague and friend, Dr. Sophie Balzora, Clinical Associate Professor of Medicine, NYU Grossman School of Medicine, Division of Gastroenterology and Hepatology at NYU Langone Health, New York, New York. Welcome, Sophie, and thanks for joining.
Oh, thank you for having me. I know those titles are a mouthful, so.
I got them out. New York, New York. I got that at least. All right, so we're going to go ahead. We're going to make this a very practical approach. We'll have some cases in a minute, but let me now review our learning objectives. Our first learning objective is to integrate recommended immunizations and preventive screenings into practice and to improve health outcomes in all patients with inflammatory bowel disease. Our second learning objective is to implement strategies to address disparities in care in patients with IBD by establishing trust, providing education, and engaging in shared decision-making, SDM. So let's start with our first case. And this is a patient that we have seen. And I think this is really, from a practical standpoint, very helpful. So this is a 39-year-old Black male who has mild pancolitis, has had actually chronic ulcerative colitis now for 8 years, family history of IBD, is at risk for colorectal cancer due to his family history, and has not yet received a flu vaccine. So before we move into the data and I turn it over to my colleagues, I'd like to get the audience involved. So this is going to be your first polling question. You'll see a question on your screen and you can choose your responses now. So the question is, what preventive care information is missing from Michael's chart? A, vaccination history, B, nutritional assessment information, C, assessment of Michael's mental health, D, smoking status, and E, all of the above. So go ahead now and vote. All right, so Sophie and Patricia, the audience, 77% said all of the above are missing. And in a second, I'm going to get to both of you. But let me ask Sophie first, kind of what's your thoughts on health maintenance? How are you looking at patients when they come to see you? Did the audience get it right?
So I'll say that the majority of the audience did get it right. I think that, the reason why we're here is because health maintenance is oftentimes overlooked, but it's so incredibly important. So for me, I like to tell patients, particularly at the initial diagnosis that, I want to have a separate visit that's completely devoted to healthcare maintenance. One, to just give it clout, right? So I think that when you say, I'm going to have an entire visit devoted to this, they say, wow, this is actually really important. And then it just allows them to digest the information better, I think, when you're just presenting that information to them, because there is a lot to go over, as we'll find. So I think having a separate visit, discussing all of the ins and outs of healthcare maintenance is really critical. So that's the approach that I take.
Great. And then Patricia, I'll get back to the case in a minute, but I wanted to pick up on something Sophie said, specific with vaccines. And we talk about the vaccines that are needed, but over the last couple of years, we've seen a lot of vaccine hesitancy. And when we talk about some of our underserved populations and some concern about vaccines, how do you address that with your patients?
Yeah, so I think you bring up a very good point. How certain patients, especially this patient who's 39, he may not think he even needs vaccines. So I try to, first of all, make them understand the rationale behind the vaccines, that they're at higher risk of infections. And so we're trying to help them. And I try to figure out what beliefs they may have of the vaccine, so I can try to dispel it and tell them, just so they know how important these are. And then obviously I make them know that this is a shared decision-making, and I'm not going to push anything upon them, but I highly recommend it. And I hope that, kind of like what Sophie said, maybe by the next visit, we can have this conversation again, and maybe they'll be more open to vaccines at that point.
Right. So education, shared decision, and again, gaining that trust. So let's get back to the case of Michael. So again, 39-year-old Black male, mild pancolitis, chronic UC for years, at risk for colorectal cancer, not had the flu vaccine, needs screening assessment. He's actually prescribed mesalamine, but he doesn't want to use rectal mesalamine. So Patricia, I'm going to turn it to you now to talk about preventive care for patients with IBD. We kind of already started this discussion, but what's your experience been in patients when they come in for prevention?
Yeah, I think when patients come in to see their gastroenterologist, prevention is not necessarily the first thing on their mind. And so I think what I try to do is I definitely address their whatever they come in with, like if it's more of an acute symptom, and then when they come back the next time, I try to address all their issues, but then I also make them aware of the fact that prevention is very important, especially in their population. Just things to know is IBD patients, they don't receive preventive care at the same rate as general medical patients, most likely because they find themselves coming to their gastroenterologist a lot, and sometimes they almost see them as their primary care doctor. And so something that I try to make sure patients are aware of is that vaccination history is important, and that working with a primary care doctor is also very important, so we can know what vaccines they've had, what vaccines they need, and have a good record of it between myself and their primary care doctor.
Right. So again, kind of that education piece, talking about the importance of health maintenance. And also, I think you kind of indirectly raised an important point. As gastroenterologists, sometimes we're almost primary care doctors, right? So we're seeing these patients, they're young, healthy, they're coming to us, and we have to really educate them. So with that, Sophie, let's move into vaccinations. Thank you, by the way. The questions are coming in. I think some of these are going to be answered, but if not, I'm going to ask Sophie at the end. And so, Sophie, it sounds like people saw you today with Katie Kirk. So just to give you a little shout out there. But anyway,
thank you.
Why don't you take us through vaccines and how do you handle vaccines in your practice?
Sure. So, I like to tell patients that, healthcare maintenance is as important as getting people into remission and keeping them there. I think that when you engender trust by getting people into remission, that will already set the stage for making it a little bit easier for patients to adhere to vaccination. So for me, I think I'm very lucky in my practice in that I have a specialty practice, a multidisciplinary practice. So I can work very easily with primary care physicians and I can offer vaccinations myself. Of course, not everybody has that luxury, but I'm definitely the first person to offer those vaccinations. But I think what's also key is not only speaking to the primary care physician, but also, documentation is key, right? I think that telling people exactly what vaccinations they need, what the schedule is going to be, what vaccinations they've received is also very helpful, so that at every touch point in a patient's journey in terms of healthcare, somebody can offer them the vaccine when they need it, right? So the primary care physician isn't confused as to whether or not the patient received a vaccine. They know which vaccinations are safe to give and which ones to avoid if the documentation is there. But I think that it really is a team approach, because I want patients to be able to get the vaccine at the infusion center, get the vaccine with me, get the vaccination at their primary care physician, because you never know when that sentinel moment is when they're finally ready, right? Because you're having these conversations over and over again, oftentimes before someone adheres. And so you want to be ready for them when they're able to get the vaccination. So I think that is really a key point, is that being able to offer it at different time points is essential. But I personally like to take charge of, vaccinations, but of course, work with, the patient's primary care physician, should they have one, to get them vaccinated as well.
And actually the questions are lighting up. One thing I'll point people to the slide here. I think it's kind of a nice, in the blue box gives you the commonly needed vaccine. So I'm not going to read all of them. Just recognize that COVID-19 is there. But Sophie, there were a number of questions as far as with the PCP. How do you communicate, or how do you let the PCP know if you've given the vaccine or vice versa?
I mean, I usually document it in the chart. It's a shared chart. Everybody's experience is obviously quite different, but I just document, the date that they received it, or when they're due. And there's also, to back that up, there's also formal documentation from the person who actually administered it, like the nurse or something like that. But I also send the chart to the physician, to the primary care physician as well. So there's different avenues, there's many different ways where they can access that information very cleanly and very easily. Or, even when I'm starting a patient on a biologic, I will let the physician know, what the implications are for that as it relates to vaccinations.
Great. So before we move to the next slide, a couple quick questions on this slide. People see that shingles, herpes zoster is listed, and there's a lot of questions about shingles. But just to summarize this, given that he's 39, would you give the shingles vaccine now or wait till 50?
I think because he's on mesalamine, he's on mesalamine, he's young. That's not somebody I would just run to give the, herpes zoster to. I think that it would be more beneficial and more impactful to focus on things like the flu vaccine, COVID-19, Hep B, or any vaccinations that he may not be able to receive if he should, if his care needs to be escalated, meaning that he'll need immunosuppressive therapy. So those are usually the ones that I would focus on in this type of patient.
Yeah, and just the thing I'll add to that is it's not wrong to give the Shingrix now. And to your point, it may just not be necessary. But now that the vaccine is available down to 18 years of age, sometimes there's still some payment reimbursement issues with it. But if this is a guy, I think to your point, if he was headed towards a advanced therapy, immunosuppressive biologic, we'd probably go ahead and give it to him. All right, so let's go ahead and move on to the next slide about vaccinations and patients with IBD. You already alluded to this, but talk a little bit more about the team aspect around vaccinations.
So, I mean, for me, I think that, involving people that the patient already trusts is vital. I think that also incorporating kind of more creative ways to facilitate receiving vaccines is also important. So again, I think that when we think about marginalized communities, when we think about areas that are underserved, I think that leveraging the community players, the community stakeholders, community leaders is essential. So that is to say, offering vaccinations at, faith-based organizations, offering vaccinations very widely at local pharmacies, having those types of relationships takes work, right? It takes work to get the trust of not only your patient, but also community members. But I think it can be very, not only impactful, but I think it just makes it seem like it's much more of a team approach. Like everybody really is trying to accomplish the same goal. So I think for areas that are particularly underserved in terms of resources, in terms of being underinsured, that's a very, tried and true way to, to increase vaccination adherence.
Great. And the one thing I'll point out to the audience on this slide here, and you put up a table from Cornerstones. This is also actually listed on the GI Hub, the CME Outfitters Hub. So you can refer to this. I think it's an incredibly useful checklist. All right, so let's move ahead and go into essential screening in patients with IBD. And Patricia, I'm going to pull you back into this just to give you kind of advanced notice on some of the questions. One of the questions had to do around screening actually it said male, but in any patient with dark skin for melanoma. So why don't you keep that question in mind, but go ahead and talk to us. What are the essential screenings in patients with IBD?
Yeah, so I mean, I guess getting the history is good to know to begin with. So in a patient who has had colitis for greater than 8 years, then I guess the easiest screening for the gastroenterologist is the colonoscopy, because you want to make sure they don't have colon cancer or colon dysplasia. That being said, in patients who are on immunosuppression, you start thinking of the other screenings because they're at risk of other things. So for our female patients, I always make sure to not forget about cervical cancer screening, because they need it even a little bit more frequently than the general public. And so I have to bring it up to them and then make sure that they're plugged in with their OB-GYN. If they're within our health network, it's great, because then I can even send a message if they're already plugged in with the OB-GYN, and I can see when they actually perform that. Other screenings to keep in mind is skin cancer. So patients who are immunosuppressives may be at higher risk of skin cancer. And so I send them over to the dermatologist, either by direct referral if they're within my system, or if they're coming from a different state, then I'll try and communicate with the primary care doctor that they should get a referral to dermatology, whichever way they can get there faster. And then other screenings, like I said, history is very important. So have they been on chronic steroids? Do I have to be thinking about DEXA scans? And then taking a step back and thinking about the patient as a whole, not to forget mental health, because IBD patients at high risk for depression and anxiety. And I think we can always start our screening on our own, but I want to make sure that they have access, if needed, to a behavioral health specialist who can I can do the initial screening, but it's good to have that so we can take them to a higher level for that. And then those are kind of the screenings that I think about and how I try to incorporate it.
Great. Yeah. So just let's pause here on this slide, because you said a few important things. And let's also not forget about, obviously, screening for latent tuberculosis, which obviously we do now. Patricia, you mentioned skin exam. And just to come back to that for a second, how often do you recommend total skin exams in your patients?
So I feel like I definitely don't feel comfortable doing it myself, but I recommend that they go to a dermatologist who is, well more versed in doing that. So I definitely recommend it to all my patients who are on any kind of immunosuppressive, because they're at higher risk for skin cancer.
Yeah. And then how about the issue with this is a Black male in terms of looking for melanoma? I think you said it already. I'm not a dermatologist. I'm terrible at looking at skin. So in fairness, I think probably the answer would be with the dermatologist. But any thoughts as you had for melanoma and somebody with darker skin or a Black male like this gentleman?
I mean, I think the only thoughts I would have is I'd try to establish a relationship with the dermatologist that they're seeing, just to make sure that they're aware of the fact that melanoma may not just appear on the skin. It could be like fungal, like in the nails and things like that, just to make sure they're all up to date. But I'd hope that the dermatologist is practicing in a place that they can equitably be able to assess skin cancer in both our lighter skin patients as well as our darker skin patients.
Great. And then Sophie, Patricia mentioned behavioral health, mental health, and I think this has become such an important topic globally, but also specifically in our IBD patients. Kind of tell us what you're doing in New York, or what your thoughts are in behavioral health aspects around IBD.
Sure. So, I mean, I think that this also touches on Patricia's point about, having dermatologists who are well-versed in taking care of people of all skin tones. I think that with mental health, there's a stigma in certain populations, right? About talking about mental health issues, about realizing that they exist and it's okay to see somebody professionally. It's the same thing with, certain skin cancers. Some Black patients may not even believe that that is a concern for them. So I think that, I hear time and time again, I'm sure Patricia gets this too, that there are patients who look like us that are so incredibly appreciative that they're seeing somebody who looks like them. And you may not have the same experience as them, but even just seeing that, the power of that is immeasurable. And so I think that it may be a little bit easier when there is that physician-patient concordance to bring those issues up in a more culturally sensitive way, or at least recognizing that it's not something that's often talked about, unfortunately, not talked about enough. And I think it is a relief off of people's shoulders when you do introduce that issue and give them the sense that this is not something that you're experiencing alone, that you're not, an N of one. This is a common thing, and this is why this is part of screening. And especially at the initial diagnosis, right? There's so many things that are running through patients' heads. So I think that bringing it up as gastroenterologists, I think it takes, it brings it surprises some people because they're like, why are you talking about this? I thought you were just a doctor I'm supposed to talk about my bloody diarrhea with. But when you bring things up like, seeing the GYN, talking about anxiety, getting your vaccinations, I think it really surprises people in a good way, because I think it just gives people the sense that, wow, like they're taking care of me completely. So that's kind of how I bring it up to people, is that you're not the only person. This is something that we absolutely need to address, because it can get in the way of your overall care and your overall health, and your ability to adhere to medications. So.
Right. I mean, such important points. And thank you for that that overview. But actually, before we go to the next slide, one more question on this, and thank you for everybody sending your questions, and I'll get to them as we move to the next case and before we wrap up the evening. But, on this slide, Patricia mentioned smoking cessation, which is obviously something we want for all of our patients who smoke. But, there's an interesting paradox in ulcerative colitis. And first of all, maybe for the audience that may not be aware of it, let us know what is that. And then how do you counsel, or what do you tell your patients with ulcerative colitis that might smoke if they quit? How do you guide them?
Yeah, I mean, for Crohn's disease, it's quite clear that smoking, has no benefit and could impact, patients' ability to get well and be in remission. But for ulcerative colitis, there is, evidence that suggests that there is some benefit to smoking. But of course, we know that there are so many, there are so many detriments to your health overall that it's not something that we recommend people take up, or that they don't quit. So will they potentially see a change in symptoms? Will it potentially affect, the medications that they'll take? I mean, it's always a possibility, but by far and away, I mean, I always recommend smoking cessation for patients.
Right. So why don't we, it's a weird thing, right? That we talk about smoking cessation. I just tell the patients they may get more symptoms, but we still want them to quit even with ulcerative colitis. Why don't we go to the next slide? And this is kind of the guidelines and the checklists. And I know it might be hard to see on your screen depending on how large your screen is, but this is a really useful kind of the guidelines. This again is listed on the CME Outfitters website, so you can obtain all of these references, the guidelines in general. And I think these, again, just get to the whole aspect of incorporating checklists into our practices. And I think that's just so critical. Let me shift now to the next case. And the next case is also going to highlight the team that we all talk about in IBD care. And I'm curious when we go through this for both Patricia and Sophie, kind of how you work with your teams and who is part of your team. So this is Anna. Anna's an Hispanic female, single parent. She's limited in English proficiency. She needs a colonoscopy, but didn't show up for her regular scheduled procedure. So let's go to the next audience response question here. So before we move on, Hispanic patients have seen an increased incidence of IBD due to A, environmental exposures, B, genetic differences, C, social determinants of health, D, incidence is not increasing, or E, I am not sure. So take a minute and answer the question. And then I think also I will reference, there was a Twitter poll out sent earlier. So if you were part of that, I'll tell you what that result was and see how it compares to this also. All right, so looks like the majority of patients said that increase in incidence of IBD due to social determinants of health. And then second was genetics. Then third was environment. And then I'm not sure, which is always a fair answer. That's fine. That's why you come to these programs. And then the fourth or the last was incidence is not increasing. Interestingly, on the Twitter poll earlier, we had the majority of respondents pick the fourth choice, which is incidence is not increasing. So Sophie, maybe I'll ask you kind of what are your thoughts on, we're seeing more of this in different populations, Hispanics included. What are your thoughts on why this may be?
Yeah, I mean, you can never really point to one thing, right? I mean, our environment absolutely is changing. I think people are recognizing social determinants of health more. I don't know if I would say that necessarily increases the incidence of IBD, but I think it at least allows us to realize that like you said, I mean, there are people who are of all colors now and of all ethnicities who are suffering from inflammatory bowel disease, where we traditionally thought it was a disease of a very small minority white population. And we're seeing much different things now as the world becomes more of, intermingled and, whatever you want to say. So I think that, I think that this brings up an important point. I think this case is going to be very interesting and what we'll discuss, but though we'll concentrate on social determinants of health, ultimately, I think a lot of it has to do with, environmental factors.
Yeah. So, and I think the slide that just you kind of advanced to are these social determinants of health. So I think you've talked about some of this, but maybe, I don't know if you want to highlight anything here or add anything to what you had said.
Sure. So, I mean, the term social determinants of health is being talked about much more often, thankfully. But basically, we're talking about environments, we're talking about communities, right? Where people play, where people raise their children, where people work, where people eat, where people live, die, pray, whatever you want to call it. And so some obviously have, better infrastructure than others. And all of that really plays a huge part in people being able to achieve their best health. So as it relates to Anna, the patient that we have in front of us, and a lot of patients that we may see, depending on where you practice, there are so many things, right? So many structural forces that resulted in her missing her appointment. And so I think that before we employ that unconscious bias that we don't realize that we're employing, or think one thing or the other when a patient doesn't come, there's so many things that we need to ask the patient well before that colonoscopy occurs, so that we can prevent these types of situations.
Yeah, and as we show you what happens in the case, I just want to make a comment first that the incidence and prevalence that we're seeing in different populations, and for this example here in this young Hispanic female, are probably multifactorial. I think the social determinants of health clearly is part of it. Some of it also is that there's an underreported aspect to IBD. Some of the patients, either culturally or just not comfortable, as you said, living in the community, just may not really want to share with anybody, not only family, but let alone a physician or a healthcare provider. The other aspect is I think there's a clear environmental signal, and we've seen this with multiple diseases. And I think as our environment is changing, and in this way, worldwide changing with diets that are becoming similar and maybe not the healthiest with higher processed foods, that may be playing a factor as well. But let's go back to Anna. So she's, again, a Latina female, single parent. She has limited English proficiency, needs the colonoscopy, has no transportation. And Sophie, you kind of already alluded to this. She receives a no-show fee from the doctor's office due to a missed appointment. And I think this is obviously a deterrent into itself. It sends a negative message, and we have no idea why she didn't show up to her appointment. Patricia, I'm gonna now kind of shift into this medical home that we have here at Cleveland. I know in New York, Sophie, we'll hear about your team-based approach. I know a lot of the good work you're doing there and with your teams, and then some of the others around the country. But just to put this briefly, and for those that haven't heard of this concept, this medical home, it's not a brick and mortar place. It's actually a concept of a wraparound care for a patient where we provide care just beyond gastroenterology. So we include other specialists. Certainly the PCP plays an important role. We shouldn't ever forget that. As a behavioral health expert, so whether it's a psychiatrist, a psychologist, social worker, the nurse practitioner, PA, dietitian, pharmacist. And really, I think it does take a village sometimes to take care of a patient. So Patricia, maybe first from you, kind of tell us your experience with the medical home and this team-based. How do you interface? How do you find that your patients are finding this team approach?
Yes, I think it's great to be at a center that has this. And I think patients see it very positively because not only do they get to see their gastroenterologist, but as we mentioned before, patients have many other needs than just their IBD. So they get to see the behavioral health specialist. And some of the younger patients are still trying to struggle with the fact that they have this chronic illness or chronic disease, especially if they didn't have it in their family previously. So I think they definitely really appreciate the behavioral health aspect of it. Additionally, having nurse practitioners and nurses who, in the case of Anna, I think would have been helpful if from the beginning they were able to tease out the social determinants of health that stopped her from coming to a colonoscopy. Like, was it a language issue? Did she not understand her prep instructions? So I feel like having like a whole team together, like the social worker, the dietitian, and patients who may have like overlying celiac plus IBD, I feel like the patient sees in a very positive way. And I feel like in the case that we discussed, it would have been very beneficial to have a medical home, because then if the physician may have missed the social determinants of health, perhaps the nursing staff or a nurse practitioner or social worker or anyone else on the team would have picked up on it.
Yeah, and I sometimes say to my patients when they're seeing us in the clinic or they've done these virtual or telemedicine visits, sometimes the patients will latch on to a team member. I thought of a patient I saw today who probably contacts our dietitian more than anybody. Patient I saw yesterday, it's our PA nurse. The point being, like you said, there's a level of trust that's established with the whole team, and each member of the team is equally important, and the patient may bond with different team members in different ways. Sophie, there's a question that came in as far as medical homes and centers of excellence. I guess one practical question is a lot of the care, or most of the care, I should say, around anything but IBD in this case is done not in these tertiary care or centers of excellence. They're done in the community. They're taken care of by primary care, gastroenterologists, APPs. Just from a practical standpoint, how does somebody find a center of excellence?
Well, I think that programs like this one, to be honest,
that was not a loaded question. I wasn't looking for that, but okay, we'll take it.
But yeah, I mean, I think that is an important start. And, when you access those resources for patients, you can see who is writing those resources, how are they accessible? Because I think a lot of people at these tertiary care centers are very much invested in just as community physicians are, of course, and just elevating the care that they deliver to patients. So I think that would be the way I would seek it out. Is just by trying to find those resources online that are geared towards patients, and then ultimately it will bring you back to who's writing them and who is kind of laying the groundwork for those sorts of things.
Yeah,
and it can be challenging. Yeah.
Yeah, no, and sometimes it is hard, and we've heard this from patients who may live 50 miles away from us and said, we never knew that this existed. And I think that one of the aspects is that kind of a certain, so the Crohn's Colitis Foundation, I think, does a very nice job on their website of listing centers, listing groups, listing those aspects. And I think that as we actually, Patricia, I'll ask you, I want to go to the next slide because there are some questions coming in here about the medical home model and the community and how do we access this. This is actually now a bunch of questions are popping up. So I think this is a good time. I'm going to say a couple comments first, and then Patricia, I'll kind of turn it to you to get some of your thoughts as well. I'll just read off some of these. I'll answer some and then I'll turn them to you. So one frustration for my patients who are referred to large centers is the time to the appointment. It's especially challenging when they're flaring. Another comment and question, how much is the medical home? How's this handled? Couldn't do this in the community. It would cost a fortune. So there's still this gap. And maybe I'll just kind of mention a couple of things. And access and time to appointment is actually very important. And it's something that is frustrating if there's a long wait. I'm hoping, and I don't want to be naive when I'm saying this, but I'm hoping when we get into these team-based models that we'll have our, say, APPs who can do even a first intake visit and maybe do it in a quicker timeline. In terms of how we pay for this, this can be done in a few ways, and not to get into too many of the details, but one way is that insurance companies are more and more paying for some of the services around behavioral health, around dietitians. I've kind of lived, if you will, in two models between Pittsburgh and Cleveland. And we're finding that these services are getting paid for. And then the other model is obviously pairing with an insurance company, which is more of a challenging, and that's not as readily done. So Patricia, on this slide, this is kind of different ways that we can actually get patients into the medical home from the community. Maybe spend just a minute or two talking about some of this and kind of how you look at accessing and pairing with our community doctors around medical homes.
Yes, so I mean, like the slide alludes to, there's different ways, and I think it's very patient specific what works best for them. There's the way of referring for the community GI physician, referring them to our medical home center, and then we take over the care. So then they have access to us, they see us on a regular basis, we take over their GI care. That may not be the best fit for everyone, and everyone may not necessarily need that. And so it's nice that we have different other options that we can do. So certain people are happy to refer for like an initial visit to take over the care and have a plan, and then they can go back to the community gastroenterologist, but they can still benefit from the other players in our medical home, like the behavioral specialists, the social workers, and kind of just communicate well between the community gastroenterologist and then all the different players. And then now, especially with the pandemic and doing more virtual things, there's always the option of doing an annual visit with a medical home, and then continue to provide care to the patient through telehealth, so virtual visits as well. So those are like the three ways that patient dependent, where they're living or how close they are and whatnot, may be helpful for them.
Right. So completely agree. Thank you for that oversight. Let's go to the back to the case. So back to Anna. So we mentioned she didn't show up for the appointment. She had a no-show fee. And the reason is she didn't have transportation. And she had a hard time just getting there. So I think this is a perfect example of where we need to really consider all social determinants with our patients. I think both of you did a nice job of outlining that. And then maybe what I'll do is just take us through the last few slides, and then I want to engage both of you in some of the questions that came in. And we know we need to provide optimal care for our underrepresented patients. Sophie, I think you did a really nice job of outlining some of this up front: health literacy, financial constraints, work constraints, language barriers, as Anna had, and transportation barriers, which was the reason she didn't show up for her colonoscopy. And then there are insurance barriers too. And I think that depending on the patient, this can be a big deterrent as well. So I'm just going to wrap us up with a couple slides, and then I'm going to get into some of the questions that are coming in here. So these are called the SMART goals, and these are specific, measurable, attainable, relevant, and timely. So we need to recognize the need for immunizations and preventive screenings for patients with IBD. We need to adhere to the guidelines and appropriate immunizations and screenings. You heard from everybody tonight: educate our patients, collaborate with primary care doctors around the importance of immunizations and screenings, integrate recommended immunizations and preventive screenings into practice. And I think this is practically done by these checklists, guidelines, and we included some of those on the website as well. And then, as in both of these cases, and I think Patricia and Sophie has done a nice job of looking at social determinants of health that these patients may be facing. So with that, before I completely conclude and get to questions, I want to thank both Patricia and Sophie for the wonderful discussions, and I really appreciate their time. And as a reminder, this is the second program in our series. I encourage you to join us for the last two live programs. The important role of preventive screening in IBD: how, who, and does it matter? November 8th from 6:30 p.m. Eastern to 7:15. And then the medical neighborhood in IBD: steps to improve care for all patients, on November 16th, also at 6:30 p.m. Eastern to 7:15 p.m. Remember, if you want to ask us a question, just hit the Ask Question tab. I see that many of you have already done that. And then include the faculty's name if you have a question for the faculty. People gave Sophie the shout out about Katie Kirk, so if you want to comment on that, you can. But let's get into the questions. A couple last questions, and then I'll leave you with the Gastroenterology Hub site as well. So, I think there are a couple questions. Actually, I'll direct this to Sophie. There are a couple questions on COVID, which I was surprised we got this far without bringing it up again. And a lot of patients, Sophie, would like the COVID vaccine and the flu vaccine at the same time. Is that okay to give them both vaccines at the same time?
I think it is okay. I think a lot of people don't like that approach just because they've heard, people have different reactions to the COVID vaccine, nothing terrible, but it may put you out for a day. Sometimes people like to space their COVID vaccine and their colonoscopy. But I mean, from a scientific standpoint, I think that there's no problem with getting both. But I think it's really patient preference. Sometimes people are just hesitant to do that, but it's totally fine. I think it's better to do that, but.
Yeah, you're absolutely right. And actually, I think as we go forward, there's even talk about combining vaccines, but it's interesting early in the pandemic, or I should say early in the vaccine portion of the pandemic. So not because vaccines obviously weren't around for the first part, but when vaccines became available, there were guidance and recommendations not to give concomitant vaccines. So the flu vaccine with COVID. Now that's gone away. So for our audience out there, you can get the flu vaccine and the COVID vaccine at the same time. There's no downside to that. And the IBD data that, again, we didn't present tonight, but Secure IBD, a registry. I know, Sophie, there's a lot of work in New York going on with this as well, has actually shown that vaccines are safe in IBD. We absolutely recommend them. In patients who are immunosuppressed, there may be a slight decrease in efficacy, but still there's some data coming out that there's still strong efficacy. We are recommending our patients get the booster vaccine as well. So I think these are important aspects. Patricia, I'm going to switch gears, and there is a question on diet, and specifically to Anna in terms of maybe culturally a diet for her. We didn't get into what she ate specifically, but in terms of diet patterns, and you could say this for any ethnicity, any culture, how do you address diet when there's such variation in diet from culture to culture, person to person?
Yeah, I think that's where the importance of having the medical home comes across, where I'm happy to admit that I may not know as much about Anna's diet, but I can work with a nutritionist to try and go over her diet, and then they can work together, and hopefully she can establish a connection with them. So I think that would be a time where I would acknowledge that I may not know all about the diet, but then we can work with the nutritionist to try and see what diet that she's on, because that she may be on a different diet than the next person, like our first patient or whatnot, and then try and figure out what's the most nutritious diet that she needs to be on.
Yeah, and I think I completely agree. And I think this is where it's a luxury working with a dietitian if you have it. There was a question on telehealth and medical homes, and do you get full reimbursement? You don't get a facility fee, obviously, with telehealth visit. But I think from a professional fee standpoint and what this affords the patient and our ability to connect, I would still obviously look to this. I'm going to end with the last couple slides, and we just want to remind people that you can visit the Gastroenterology Hub, hear the resources, the link. A lot of what I presented tonight as far as the checklist are on that. And then finally, remember to receive credit, to receive CME and CE credit. Participants must complete the post-test evaluation, and participants will be able to download and print their certificate immediately upon completion. Sophie, I'm going to give you the final word before closing out. Any final tips from tonight's program or anything you want to leave the audience before we sign off?
I mean, I am very excited that people tuned in, because I think that it just emphasizes the fact that people are thinking about this and thinking about different ways to approach it, and just trying to, again, better the outcomes of patients, particularly as it relates to preventive health, because I think that that's gaining a lot of traction, and it's wonderful to see.
Great. So again, thank you, Patricia. Thank you, Sophie. Thanks to our audience. Everybody stay safe and well. It's nice seeing everybody. Thank you very much.
Bye-bye.